Good morning, everybody. Welcome to our latest webinar. My name is Professor Paul Tipton. I am President of the British Academy of Restorative Dentistry and Director of Tipton Training. So today's webinar is a slightly different topic in that we're going to be talking about dentures. And one denture in particular, which is the stable base denture. Now, the stable base denture is a specific denture which is made for mucosal-borne dentures. So it's a mucosal-borne style of denture. So what we're going to run through today is these five major topics in the overall topic of stable base dentures. We're going to look at partial denture design, some of the problems with it, the stable base design and how the stable base design then succeeds where some of the other partial denture designs don't. We're going to look at success rates, we're going to look at techniques, and we're also then going to go through some case studies. So first of all, a problem with many partial dentures is the difference in mobility, especially intrusion, if you like, and soft tissue displacement in comparison to what is happening with the tooth. So we know that under occlusal loading, teeth move a little bit, but soft tissue moves up to 13 times as much. And this can produce torquing in the partial denture and especially in the abutments. And what happens an awful lot is for partial denture design, we've got clasps, but also over the years, we've been involved in making different sorts of attachment and take into consideration this differential movement. And in the screen in front of you now, you can see the Dalbo attachment here, and you can also see a Seeker attachment. These also were brought out to allow this differentially with free end saddles. That's what we're going to be talking about in this presentation, the free end saddle partial denture. And one of our problems and one of the solutions that the Dalbo and Seeker attachment tried to address was this vertical displacement with the free end saddle. No matter what happens, if we have attachments on the distal aspect of our abutments for these typical free end saddles here, then as we bite up and down at the back, the mucosa will more than the teeth, and so we get this amount of rotation. Now, the Seeker and the Dalbo attachments have been made so that they can take this sort of displacement. They move and rotate. However, at some stage, once we're having this mucosa and we get a little bit of alveolar bone underneath that stable base, then the amount of torquing that we're going to get and the amount of movement that the Dalbo and Seekers can in effect transfer the load to, that amount will start to overload possibly the attachment itself and also the tooth. That's where our problem arrives. Now, if we look more closely at the Seekers, are one of the types of precision attachments that we've used over the years. If anybody's interested, there's an excellent book, which I'm just holding up here, by Harold Preschool that discusses design, especially using precision attachments. And there's an awful lot in the book about Seekers and Dalbos and the use of them. We use them very often, or we have used them very often in the past. Typical case here, you'll see where the upper anterior teeth are still in place. They've in fact been splinted, and this is again one of the sides of using the Seeker and the Dalbo is that most of the time you cannot just use one tooth. If you use just one tooth, if we just go back here, then we've got too much torque, rotational stress on one tooth only. So the idea behind the Dalbo and Seeker was that you splinted at least two teeth together, very often more teeth together. Now, of course, when we come into any design where we have splinted crowns, we all know that splinted crowns lead to a reduction in success. And we know from British design studies over the years The more abutments you splint together, then the reduction in success rates. So even though we're using these attachments in an effort trying to take the stress off the abutment teeth, we will get these rotational stresses, which will, unfortunately, when we splint a lot of teeth together, cause long-term damage and problems with the abutment teeth. Straight away, you can see that we've got problems with long connectors. We've got periodontal problems potentially affecting these teeth. And here's our classic seeker, and there's our other classic seeker. For attachment of a partial denture, which is more design. So here we have a typical precision attachment with seeker attachments to try to consider this off-axis loading effect using many splinted teeth. So we're using 1, 2, 3, 4, 5, 6, 7 splinted teeth. I know a couple of them here at Pontic, so we're using 5 abutments. And as you know, when we put this load on many splinted teeth, the chances are at some stage that we'll have cementation failure in one of the abutments, or one of the abutments may fracture off. And of course, we have no way of knowing if that has occurred because we've got splinting of all the rest of the teeth. So with this sort of skeletal design, which digs into the soft tissue, remember, it's displacing 13 times as much. Whilst we get very, very good short-term results, the long term is disappointing. And long-term, the base needs to be either remade or relined as we get alveolar bone resorption on the ridges. Here's another where we've got a partial denture design using seekers. So we've got seeker attachments here for replacements of 6 missing lower anterior teeth. They were lost an accident. And if we look carefully, we did retainers both sides, and we've also got a milled lingual bar or lingual aspect for the partial denture to sit into. And here's our partial denture now sitting beautifully into those milled lingual areas. So this is precision dentistry. This is very, very precise, and it's beautifully, technically well made. However, our problem occurs again when we look at this being seated, and we've got resorption there already. When we have more and more resorption over the next few years, then this will more, and as it tilts more, it puts more stress on the seeker attachments, which in themselves then starts to put off-axis loading on both of the abutments. And in the long term, there is a chance that one of these will come uncemented, or one of them will fracture off at gum level. And there's our initial definitive restoration, which we have in fact gone and changed to a conventional fixed bridge. So let's look at the stable base design, and let's see now changes what we've discussed with our conventional partial denture design. And again, I remind you that we're talking here about partial denture designs for free and sound that are mucosal borne. I'm not talking during this presentation about tooth-borne partial dentures. Problems we have of trying to create stable occlusion where the missing teeth are also taking some of the occlusal load. So several papers on this which I'd like to discuss with you. Nick Cap, you may know Nick. Nick was one of my tutors, lecturers down at the Eastman. He produced a very nice paper we can go back and have a look at, an alternative approach to restoration of distal extension saddles. And again, he discusses the stable base dentures produce a simple way of restoring the distal extension saddles when the abutment teeth require cast restorations. The advantage, or one of the many advantages of the stable base denture, is the fact that you do not have to splint teeth. And you don't have to splint teeth because you're going to be using intracoronal attachments, not Dalbo, that seeker I showed you previously. They're both extra the force are going the long axis, creating off axis loading. The examples of our stable base denture. Okay, and again, it's a different style of denture. It's a denture where we're going to be using fixed movable attachments. It's a denture which is going to be chrome, which is sandblasted. It's a denture that will have ceramic or gold occlusal surfaces. Joe Clayton also discussed this, and he's got a classic paper which I'll discuss with you in a minute. And whether or not the soft tissue can be compressed has not been shown scientifically. However, if it is possible, then pure compression will be very little. And some people have gone and looked at the base denture technique and likened it to a waterbed. So bear with me. Any of you ever had a waterbed or sat on a waterbed? If you sit in the middle of a waterbed, okay, let's just say it's a single bed, sit in the middle of a waterbed, what happens to you? So the water, you sit on the waterbed, the waterbed displaces and you sink in. Now what happens if you had, let's say, a piece of wood which is exactly the same size as the waterbed? You put the door, the piece of wood onto the waterbed and you then sat it. What would happen? Water cannot displace. Water then can only compress, okay? And it will only be compressed by a minute amount because tissue can only be compressed by a minute amount. The problem with most skeletal designs is that they will go to the soft tissue, the water will displace and they will sink in. And that is again where we then have a working problem. So one of the key issues which we resolve with the stable base is that we cover the maximum amount of palatal tissue or lower ridge, so that we then do not get soft tissue moisture displacing. And if you want to look up one of the original papers, Joe Clayton, you may or may not know him. He's from Michigan University. My occlusal teaching has been passed down from Michigan. So the guys that taught me occlusion at the Eastman Dental Hospital, that was Nick Kapp, Judith Wickens, Richard Eilenberg, all of those, Richard Ibbotson, they were all been trained via Michigan. So they've all been to Michigan University or been trained by Michigan people. So again, I've got that Michigan philosophy, 5 principles of occlusion, and Joe Clayton was the head teacher at Michigan. And he came up with this philosophy of the stable base denture very much as an occlusal concept. So the stable base gains its retention from an intimate fit of the sandblasted base with the healthy tissue. So we've got to import healthy tissue. We'll see, go through the technique. If the patient's wearing an existing partial denture, that partial denture has to be left out between 48 hours, possibly up to, so we can get tissue back into a healthy state. We need to be very detailed, mucostatic, not mucocompressive, very detailed that soft tissue, so the soft tissue does not displace. And because the base itself, as we mentioned here, the fit of it, the sandblasted base, the fit to the soft tissue, and again, the idea, the concept, like 2 glass slides, you've all at stage put 2 glass slides together with either water in between them or saliva. It's almost impossible to take them apart this way. All that's happened, all you can do is take them apart this way. The reason we cannot take them apart that way is because we have some fit of the 2 glass slides, and we have a very, very minute amount of glue, we'll call it glue, which holds both together. So again, that's the idea behind the stable base. So the base has 5 different concepts. Okay, so it's for tissue-borne only, mucosal-borne only. And we can use this very much for full dentures as well if we want to get a better fitting base. Works best because it works best on horizontal surfaces, not on vertical surfaces. So it's really, really good for the shallow, don't have very big ridges. So the flat ridges, some of the most difficult cases you're ever going to see, those are the best cases to use with a stable base because we use horizontal walls, horizontal surfaces, not vertical. Important that the fitting surface is sandblasted. Okay, that way we get this very intimate fit. We know that we get much better resistance, form and retention from a sandblasted surface rather than a smooth surface. So I don't know why chrome dentures are electro. For me, chrome dentures should be sandblasted so they will give a better and better retention. We're going to use porcelain or gold occlusal surfaces. Why? Because we want a stable occlusal surface, a stable base, stable base. We can load the post teeth that we're replacing, can therefore take some of the occlusal loading. So we don't want to have soft acrylic, which is going to wear. If the soft acrylic wears, and you know yourself from your full dentures that you've ever made, your partial dentures, if somebody does clench and grind a little bit, then those dentures, those acrylic dentures flatten off and wear very, very rapidly. Okay? We don't want wear of the posterior teeth. We're going to be using fixed movable intracoronal attachment. And that's a hugely important part. They will give us our guide planes for insertion. They will help to stop the lateral movements, and they will make sure that we've got intracoronal forces. So we don't have any off-axis loading on our abutment teeth. And that allows us now not to have to go and splint crowns or teeth together. And then at the end, the margin, so sandblasted base margins are polished. To show you some of these concepts, here we have a typical upper and lower stable base denture. Okay, and let's look at it, what we can see. We've got a free end saddle on the upper left-hand side. We've got a missing bounded saddle on the right. And yes, I could easily go and place a fixed bridge or fixed movable bridge on this side, but I'm struggling to do anything on that side. So the patient's going to have to wear a denture or have some implants in any case. So there's no point in a situation like this if the patient says, I don't want implants. There's no real way that you can go and put 3 teeth back in that area other than with a partial denture. So whilst we'll try and use implants most of the time, or we'll try and use bridge work most of the time, in those situations where we have the long, large free end saddle and we can't do implants and bridge work, then this is where the mucosal borne stable base denture comes into its own. We're covering a lot of the palate. We don't usually cover the rouge eye here, but we cover a lot of the palate. So this is not just a very, very thin skeletal design. We cover a lot of the palate. You can see the fixed movable attachments here, here, and here again with the fixed movable. Remember, for the fixed movable to work properly, we have to take a little bit off the base of the male. So allow the movement up down. It's with a fixed, it's going to be with a stable base denture. Compression of the soft tissue, we need to take a little bit off the base of the male. And the amount that we take off is usually in the region of 1/4 millimeter or so. Again, same thing in the lower. We've got single crowns. We happen to have a bridge here, but that's just the way the restoration was. But we have single crowns here and here for natural teeth. And again, the same style of fixed movable design. Let's look at some other designs for you. An example of the sandblasted base and also the polished, you can just see here and here. Again, fixed movable attachments. Here's our female for the fixed movable. Again, another design covering a large amount of the pallet. In this instance, we've got a bilateral free end saddle, and we're using, again, fixed movables into the distal aspects of the knot. And again, this is our traditional fixed movable joint. So remember it, it's a male and a female. There's the male, here's the male inside the female, and we take a little bit off the base of the male, whether this is in a bridge or a stable base denture. It's the same concept, to a little bit of rebound, that bouncing up and down. And again, we have another style, another stable base denture, where we're now only got teeth on the upper left-hand side. From the central incisor backwards, all the teeth have been lost. And here we're putting an attachment into the distal aspect of the central and the distal aspect of the upper left first premolar and mesial aspect of the molar. And again, here are the attachments in closer view. The male attachment is attached to the denture. The female is inside the crown. So as we bite up and down, those forces are going down the long axis. And again, there's our male-female, and there's our male-female. Again, another old skeletal design, which had seekers. The seekers had failed, and we had, in fact, some debonding of the splinted crowns. We go back, we unsplint the crowns, we do a bridge, as it happens in this area, and then we go and put the stable base concept into work, this time with fixed movable designs. So what are the success rates for these styles of dentures? The success rates are very, very good. We look over, again, this is Joe Clayton's work, over 10 years, 77 stable base dentures were made. And this is, again, at Michigan University, and none required any form of retention other than that provided by the base. So remember, the fixed movables are not giving you retention. It's the base that gives you retention. The fixed movables are giving you a path of insertion and stopping any lateral movement. Remember with the slides, if you've got slides, they will not come apart this way, they'll come apart this way. So we need something that stops the bases from moving this way, okay? Base is moving this way from side to side. Hence, the fixed movables stop the bases moving from side to side, so that the retention of the base on the soft tissue is done. We expect 10 to 15 years of service out of the stable base before it's time to go and either replace or reline. The flatter the ridge, the better it's going to be, because remember, we then have more horizontal surfaces. V-shaped ridges, ridges with very, very big, deep palates, they're not good because we don't have as much. It's the horizontal tissue that we're using. And we're using these parallel sided guide planes, as in the fixed movable attachments. This is one method of providing those planes, and it's the horizontal guide planes, etc. And we've got the forces up and down. Remember the toppy pull on the denture, which will want to displace it. That's when the sandblasted base and the soft tissue with the saliva in between stops and stops the base displacing. So let's go through and look at the techniques. And the techniques involved in the stable base are very, very interesting. So I'm going to tell you through now the different stages of all the techniques. Now, if you want to look at a paper which shows you stage by stage, and I'm only going to just go over the surface. This is the paper. So please take a note of this particular paper, and it's got all the clinical stages, okay, mapping them out in detail, exactly how we do each stage. So in terms of appointments, our appointments are going to be approximately 6 appointments to make the stable base denture. And we're going to illustrate this on a set of phantom head models so we can really get into and see what we're doing. And we're going to describe the clinical methods and also what's going to be happening in the lab, because this is a very lab sensitive technique as well. So our first appointment is a simple appointment, and we want to take stock impressions so that we can make special trays. Okay? We're going to have several sets of special trays. We have a special tray that takes the impression of the base. We're going to have a special tray that's of the crowns. We're going to have a special tray that does a pickup. So 3 special trays minimum for each of the restoration to do. And we're going to show you an upper and also a lower. Now, the initial impression has got to be mucostatic. So when we're going to be doing our initial impression, our proper impression, we're going to be a mucostatic. So it means again that the denture has to be out. So I would like my patient's denture to be out for 48, even 2 hours before my impressions, before my special tray impressions, both of those. So I'm trying to get as much accuracy as I possibly can. The second thing you want to think about in terms of when you do especially your special tray impressions is making sure that there's the least amount of saliva there. We've got 2 methods of taking our impression, you'll see in a minute. One zinc oxide eugenol, and the other one is a normal material. Light body impression material will be preferential, not good if we have lots of saliva. If we have lots of saliva, then I'll go to zinc and eugenol. But remember, we've got various drugs which we can give our patients if it needs be to dry the mouth. So it can be with some patients, we dry the mouth with some medicaments. Alternatively, if you really want to do this well, before impression, you fill the mouth up with some tissues. The mouth with some tissues, especially the upper jaw. And we're not talking the lower jaw and pooling of fiber. We're now talking about the actual mucosa and trying to dry the mucosa. So as I mentioned, we've got zinc oxide and eugenol as an impression material, or addition cured silicone. And the use depends on how dry we can get that mouth. I would like to use, if possible, an addition cured silicone. So here we are, here's our patient, and we're going to be doing a stable base denture, bounded saddle one side, unbounded the other side, and then a classic unbounded saddles on the lower. So at our second appointment, we now have to go and take these impressions. Our second appointment, we will have our special trays. We'll have 2 made, okay? Already, we have 3 in total, but we'll have 2 ready for this appointment. And what we're going to do at this appointment is, number 1, start to prepare our crowns. Now, we need to have crowns on the teeth so that we can have the fixed movable attachments in place. So if we've got here all the teeth that are bounding the edentulous spaces need to have crowns, or you could make them with inlays. Okay, could be inlays, metal inlays as well, on 3/4 crowns, classic Schillingberg style preparations. But we need to have the fixed movable attachment in here, fixed movable in there, and fixed movable in there. 3 attachments for this upper. For this lower, attachment in here in the canine and the attachment in the premolar. So again, this is not going to be a cheap restoration. This is a stable base, removable partial denture, but it's going to be with 3 crowns in the upper and 2 crowns in the lower. So our second point is going to be initially tooth preparation. And we're going to prepare those teeth, but prepare them also to make sure that we've got those spaces. So we've got an intracoronal attachment. Now, first of all, this is not the same as preparing teeth for fixed bridge work. preparing teeth for fixed movables or crowns. We do not need a path of insertion. These bridge preparations or crown preparations do not need to be parallel to each other. So we do an ideal crown preparation, but we also need to do a box preparation to house the fixed movable. So here we are on the upper right-hand side. We're going to be doing crown preparations on both of these teeth. And straight away, you'll see there's a different orientation, which we would expect. If this was going to be a fixed bridge, both of these abutments would need to be parallel. The mesial would need to be parallel to the mesial. The distal of the three parallel to the distal of the 6 here. The long axis of the 6, the long axis of the 3 would need to be parallel. However, we don't need it here. All we're doing is our best preparation, most resistance retention formed down the long axis of the tooth to minimize our tooth preparation, but we'll also have to put these box preparations in place. Same thing on the other side. We're just obviously doing one crown preparation. Again, emphasize, these do not have to be parallel in any way. The technician will parallel up the slots inside the crowns. They're all parallel, so the slots fit in at one time. So the technician will do all of this work for you. You just do your crown preps. However, what we do need is box preparations for the fixed movable. So we're going to have classic Schillingberg crown preps here with metal wings, okay? So, or with wings on the preparation. So we have, if needs be, ceramic on the labial aspect, and then a metal finish line around the mesial, distal, and palatal aspects. But we need to cut these boxes, and these are the shapes of the boxes that we can cut. Okay, there's the shapes of the boxes. Now, the fixed movable attachment, usually made by Sondre Mateur, and it comes to you as a plastic burnout in the region of about $30. So it's useful for you to go and buy one separately, ask your technician to supply one, and then you've got a plastic burnout. You can then, as you're doing your tooth preparation, put that plastic burnout pattern, okay, into the distal of your preparation to make sure that it fits there. If it doesn't, you have to prep a little bit wider or a little bit deeper. Otherwise, you're going to have off-axis loading. Now, again, if we just have a timeout, we've also got to think about something else here, which is the amount of tooth destruction versus off-axis loading. And if it bothers you, if we're doing now a very healthy tooth preparation, so there's nothing wrong with the tooth whatsoever, but you're going to put this crown on it so you can have the attachment, then there is the tendency to make that box preparation less deep, cut less tissue away. And therefore, the fixed movable will lie on the edge so that it's between the tooth and maybe the gingival margin, the interdental col, so that when forces are applied to it, there's a little bit of off-axis loading. Now, think about that compared with the opposite, which is my 4 here has an MOD amalgam in it. And now I can cut a nice deep box preparation, just basically taking out the distal box of the amalgam, so I can house my fixed movable intracoronally. So ideally intracoronally, but sometimes you may decide to be a little bit more conservative with your tooth preparation. That is your call. And the same thing in the lower, we've got our crown preparations here, and again, we've got our box preparations. So appointment number 2 is, first of all, to do our tooth preparation. Once we've done our tooth preparation, we will now take an impression in our special tray. Now, even though we're going to, that's just going to be an impression for the crowns, that's all. I want it to pick up as much soft tissue as possible. We're not going to make the base on that impression. We're going to make the base on a separate impression. So I'm going to do now a second impression just for the soft tissue. So one impression for the crowns with as good a impression of the soft tissues as possible, but that's not my definitive to the soft tissues. And then a second impression, which is going to be my definitive of the soft tissues. So I'm going to take a special tray imp for the stable base and imps for the crowns. So here's my special tray impressions for the stable base. What you will notice is that we've got an open top tray. Why? And that's going to be the same for the top and the bottom. The whole purpose is I just want to record the soft tissue. If I've got impression material, especially if I'm using zinc oxide and eugenol, if I've got impression material that's going to go into interdental embrasures, if somebody's missing an interdental papilla, for instance, we're going to get impression material there. It locks in. When you take it out, it tears. Anytime something comes out of the mouth and it tears, there will be a loss of accuracy. So all I am doing here, I'll say it again, is wanting to take an impression of the bases, okay, of the ridges. So I'm going to leave that with no top to it. So when I take an impression, then all the excess will come out of the top and it will be removed very, very easily. I don't want really an awful lot of impression material here. I just want to record the sublingual aspect. And the same thing with the upper. I'll have a hole in the upper so that I'm just creating an impression of the soft tissue areas. And then I've got another impression, which I'm going to take of my crown work, traditional two-chord technique, just like we're going to be taking impressions for normal standard crown. However, it's done with a special tray, so I can get as good an impression as I possibly can of the bases and soft tissue as well. Now, why are we doing that? At some stage in this technique, you're going to see we're going to make the crowns on one model. We're then going to transfer the base, which we've made on a separate model, to that first model. And in order to try to get it to fit as well as we can, we're going to try to make sure that the impression for our crowns is as good as we can make it of the soft tissue and mucosa. You'll see it as we go along. So that is my appointment number 2. Appointment number 1, stop tray impression. Ideally, keep the old partial denture out for 48, 72 hours. Second appointment is 2 impressions. Okay, 2 impressions of the upper. If you're doing the lower as well, 2 impressions of the lower. It's also tooth preparation, and it's impression for stable base, the soft tissues, impression for the crowns. Okay, now let's go and see what's going to happen in the lab. And the lab at this stage to make 2 things. Start to make the base itself, and remember, we've got soft tissue. So make the base on the soft tissue model. Okay, and they're also going to make something called the struts. So the actual base can be fabricated independently at any stage during this process. Okay, it would not have to be on number 2 appointment. We could take maybe the impression for the base at a 3rd appointment. It just so means that we don't have to do it at the same time. Okay, 2 separate impressions, 1 for crowns. So let's look at our lab technique. So we're going to be looking to make 2 different things here. First of all, the metal bases, and then the struts. So we'll talk and tell you what these struts are. So let's look at the metal bases. So here's our metal bases, which are going to be made. Remember, we've got a nice impression there. Mucostatic impression, dried mouth, really good saliva removal due to medication or using tissues, addition cured silicone, or zinc oxide, okay? And from that model, that impression, we pour up a master model and makes the base. Now, what do we know about the base? First of all, the bases will not go into undercut areas. So where the maximum bulbosity of the ridge is, that is where the base will finish, the maximum bulbosity. It does not go into undercut. Secondly, it's sandblasted. We have a very smooth, polished mud. And you can see here it's been made so that we can add acrylic. It's got these little balls or roughened surface so we can add acrylic. And here's our beautiful polished edges and sandblasted. Same thing in the lower, polished margins, sandblasted under surface. Now let's look at the strut fabrication. First of all, what is a strut? Well, the strut is going to be a device, a piece of metalwork that is linking the male portion of the fixed movable to the denture. So remember, the fixed movable, two portions, female, which is going to be housed inside the crown, and the male, which is going to be housed on the denture. But we've got to find a way of getting the male to stick to the denture. And we do this by a strut. Here's our male female that we discussed a little bit earlier. And this is from Sondre Matter. And this is very a plastic burnout. Okay, and here is the female, and there is the male. And the male simply slides into the female. You can imagine this is waxed up to our crown. And we then have the female aspect in metal. This is waxed up, it is then cast, and it is then going to form the male portion, and we're going to add. So here we are, what we've done so far. The technician now, before we go to the strut construction, what he does first of all is he starts to make the crowns. And he makes the crown either in their just opaque layer, it doesn't really matter at this stage. So this is the base of the crown, the metal substructure with the opaque on, or he can go and make the full crown if he wants to. Remember, at this stage, you've not really done a jaw registration, so it's not ideal to go and do the full crown so far just yet. But if you had done a jaw registration at appointment number 2, then he can start to make the crown. In any case, the crown would be made in its biscuit bake. That would be, so it's in its unglazed ceramic. Okay. Model. Okay, and inside that crown is the female, which is cast up in metal. Now the male, which is just plastic. Let's go back one. Okay, now the male, this is the male, is inserted into metal male, and this is just cut off. Go back again. I'm cutting off this portion. So I've got the male portion. I don't have the. Hi guys, we're back again. So let's continue. So the plastic burnout, we cut the top of the plastic burnout and the handle away. We then insert the bottom into the part of the base, which has already been made on one model, is now transferred to the master model with crowns on. Now you see the reason why we soft tissue when we do our crown impression, and that's why it's important that we do this with a special tray. Okay, it's made on a separate impression, separate model, but we now transfer the model with the crowns on. Now these are the struts. This is some wax, and it's rotated around, so it's. Okay, guys, back again. Let's hope that's better now, and we've solved the problem. So let's recap. The male plastic portion is placed into the female. The female's already been cast up as part of the crown. We then make the strut. The strut is some curly wax, which is added onto the plastic male portion. Okay, and you can see that at the moment it's waxed up, so it's fitting above the metal base. It's important that this strut does not touch the metal base. It lies about 1 millimeter above it. We then do exactly the same to the lower, and here again you can see the crown, the lower crown, in metal form with opaque on top. Here's our male fitting into the female. Here is the wax that's been waxed up, curly wax, and it's about 1 millimeter above the metal base. These are called our struts. So here we can see the upper and the lower ready to go. So the next stage is going to be that our technician is going to cast those struts in metal. So we will have the male portion as a separate portion with curly metal attached to it. So here we are again now, they've been cast up, and you can see again that it's important that the male is fitting into the female and that the curly struts are 1 millimeter above the metal base. Again, all made by the technician, 1 millimeter above the metal base. And in the lower, exactly the same thing, strut 1 millimeter above the metal base. And here's just for this particular case, the 5 crowns made with the 5 struts already in place, attached to the male portion in the crowns. Okay, our next stage is going to be to take this now back to the mouth. So we're going to, at this stage, try in the metal base, and we're going to also try in these struts. So the first thing for appointment number 3 is trying in the metal base. So we'll try in the crowns, okay? These crowns at the moment, unless they are in the biscuit make, in which case we can try them in and we can adjust the occlusion. At this stage, there's no need to adjust the occlusion because these have just got opaque on and they should not be in contact with the opposing dentition at all. So I'm trying the crowns in just to make sure that the crowns are seating fine. I'm trying the bases in now to make sure that the bases are seating fine. Once we do try these bases in, then we need to do a little test to make sure that the bases are stable. And the test is push up on one side. So whichever base it is, okay, push down on one side, lower, and make sure that the other side does not tip up. If the other side tips up, we don't have a good impression and a good accurate master model. So the saddle should not displace if you push down on one of them. So we're trying in the crowns, we're trying in the base separately. Next stage is, as long as the bases fit well, and at this stage, you put it in place. You test it initially with the patient talking. So please talk to me. And that stable base with the mucosa intimately fitting should stay there. Retention wise should not drop down. If it does drop down, you need to go back a stage and take another impression of the soft tissue. Okay. And the second part of that is, as we mentioned, push on the base. It should not move as you push on the base. So we have a good base. Next, attach the struts to the stable base. Into the crown, tried everything in and it fits, is to locate the strut and the base together. Okay, so we're at this stage. We're now going to link the two together in the mouth using Duralay. Okay, those of you who have used Duralay before, it is a red acrylic. We use it with the bead-on technique. For those of you who do or do not know the bead-on technique, hugely important part of restorative dentistry, understanding the bead-on technique. Let me just walk you through it. So for Duralay, we use this for all sorts of acrylic, where we want to be very precise about where we put the acrylic. So for Duralay and the bead-on technique, 2 Dappens dishes, one full of liquid and one full of powder. We also need a horsehair brush at an angle, usually about 45-degree angle, horsehair, not acrylic, not plastic, but horsehair. Horsehair brush where it comes down to a thin point as well. Okay, and some tissue. So what we do now is we put the horsehair brush, the tip, just the tip, into the liquid. So the tip of it is wet. We now put the tip back into the powder. We take it straight out and you find that there's a ball of Duralay that starts to form. Okay, now if you left that, put that to one side, came back 10 minutes later, 5 minutes later, you've got a really hard ball of Duralay there, hard acrylic, completely set. The brush is useless, you've got to throw it away. So we take that, the struts, and we also add some Duralay there. Again, sorry about this, guys. What we will do is obviously once this webinar has been completed, we will take the recording and we'll slice out the bits where we've lost connection, and we will then make that webinar as a whole available for you to view again. So hopefully, even though we are getting a bit disjointed, you'll be able to follow it now and follow it even better when we have our final webinar available to us. So where have we got to? We've got to the stage where we were using Duralay to connect the struts to the base. So we put the tip, just the tip, into the liquid, just the tip into the powder. We pick up a ball. We now paint that ball where we want to on the strut or the base. Now, important technique following now. We now come back with that paintbrush, horsehair paintbrush, put it into the liquid again, thoroughly wash it into the liquid, dry it on the tissue, and now dip the tip into the liquid, into the powder, and pick it up. So this routine is really, really important if you want to have some good success. Okay, so horsehair brush into liquid, into powder, pick up the ball, go to the mouth, deposit that Duralay where you want to. Come back, wash in the liquid, dry on the tissue, make it come to a point again, a nice thin point. Now back into the liquid, into the powder, pick up a ball, go to the mouth, deposit the ball. Come back and use that routine all the time. If you don't use that routine, you won't have the best handling that you can do with the Duralay. And you'll get excess Duralay, it'll start to set on your brush and it becomes a nightmare. So it has to be that set routine. So we now add it, and we've now fastened in the mouth the crowns, the struts, and the base together. Important again that this base is sitting there. You're not pushing down on it. The base in it is in its most passive position. And you can now see the Duralay that's linked crowns, struts, fixed movable, and base together. We do exactly the same thing in the upper. Add the Duralay between the struts in the upper and the metal base. And again, here's our struts now attached. So everything in the mouth is now passively seating together. Our next stage of appointment 3 is to take a pickup impression of it. So this is where our third special tray is now going to come in handy. And what we do is we take a pickup impression. Okay, does not have to be too detailed. Okay, so that is not a detailed impression of the soft tissue of the crowns. This is a locating impression. So this is just an impression picking both of them up. We'll now cast a master model, which will have the ideal correct relationship between crown, fixed movable attachment, strut, and base. And we do that now for the upper and the lower. Okay, we pick up our impressions. Okay, so we're now back to our fourth appointment. So what's our technician going to do? Technician is going to cast up a master model. Okay, at this stage, we may well decide we're going to do a jaw registration, a preliminary jaw registration. We might do a face bow registration. But what our technician is going to send us back now for our appointment number 4 is wax bite blocks. And we'll do a traditional wax bite block style of occlusion registration. So he again sends us back the crowns, not in their biscuit bake, just with their opaque on. And he sends us back the bases with the struts attached to the bases. So the male is now in the base, attached to the base. And on the bases, he goes and puts his traditional wax bite blocks. And what we're going to do now, remember, this is going to be a bimanual manipulation. This is a reorganized approach. So I'm going to be tapping the teeth together with the condyles in RAP and making sure that when my teeth are together, I've got the bite blocks also linked together. So our traditional, heat up the bite blocks, tap the patient together, make sure he's closing together and the bite blocks are attached to each other. And we do our traditional bite. That goes back to technician. What's technician going to do now? Now he's going to go through all the normal stages. So at this stage now, he's going to mount this on the articulator with a face bow, with that jaw registration, and he's now going to put the teeth on. The teeth are going to be, as we mentioned, either ceramic or gold teeth. In this case, they're going to be ceramic teeth. He's going to put the ceramic teeth onto the base, and we're now going to go through appointment number 5, try in the dentures and the crowns and start to shape them. So now our crowns have been made in the biscuit bake. So our crowns are finalized with the biscuit bake and the base itself. And we've now got ceramic crowns in wax. So again, we can do this just like we do normally a partial denture. If the occlusion's out, we can heat up the wax. We can move those teeth around a little bit so we get a really, really good occlusion. And what I'm looking for is contact on my stable bases, on the teeth, okay, at exactly the same time as I'm getting contact on my crowns, on my teeth. So I want contact on my teeth, my crowns, and the ceramic denture teeth at the same time. And again, just trying them in. And you can see what these are now starting to look like. Go back to the lab, and of course now we're into our fit stage. So appointment now number 6, everything's going to come back and be fitted and cemented. So there's the restorations come back, the biscuit bake ceramic, and any adjustments we've done to make sure that the bite, the occlusion's correct. The adjustments will be polished, and then the crowns glazed. So we'll have definitive crowns glazed with the female attachments in them. We'll have the male attachments sitting in. So at this stage, we're going to now cement the crowns in place. We will now also, with the males, take 1/4 millimeter off the base of the male so that we can allow them to move up and down. And we'll do any further final occlusal adjustments. So here's our metal bases now with the males attached. You can see the males attached in here, male attached just there in the lower. Same thing in the upper. Here's our metal bases, male attached, male attached, male attached, male attached. So the crowns are cemented, the restorations are seated. We check to make sure that the male's not hitting the base of the female. So we've got this springiness, this bounciness, compressibility of the soft tissue, which is very, very small because we're covering large amounts of the soft tissue and those ridges. And here's now our definitive restorations completed. So that's our 6-stage appointments that go towards making our stable base dentures. Now let's go through some case studies. I just want to go through 3 or 4 case studies for you now to show you the different types of case that we'll take on board. And as I mentioned, all these are going to be slightly varied. I've picked several cases because they're very, very varied in the way that we're going to work with them. So let's look at case study number 1, classic stable base, where we've got a free end saddle one side, bounded saddle the other side. We've done crowns on 2. So with the previous technique where we had a bounded saddle, we did crowns on both teeth bounding the saddle. You don't have to. The minimum requirement is a male female one side and a male female the other side. So here's my female attachment, as you can see on the crown on the lower right molar. We've done nothing to the lower right premolar in this case. We don't have to. And we've got a crown on the lower left first premolar. If we look at this a little bit more closely, here's our female attachment in the crown. Here is our denture with the male attachment ready to fit into the female of the molar, and with our molar teeth replaced with the male portion ready to fit into the female on the lower left premolar. And here it is now seated in the mouth. Okay, male fitting into female. You can't see just here, but again, male fitting into female. Easy, straightforward case. Okay, let's look at some other types. Okay, next study. This is a difficult case. So we've got somebody completely edentulous in the upper jaw, and look what he's got remaining. He's got 5 post crowns remaining in the lower. These teeth have been root filled. They've had posts in place. What I've done at this stage is not going back and replace the posts, because there's a huge chance that we're going to fracture the roots. So all I've done is gone and made new crowns. Now on the new crowns, we've made on the canine here a fixed movable attachment, and on the lateral incisor here we've gone and done a, again, fixed movable attachment in the crown, and we've made our stable base. Now what is ideal here is if this was going to be a traditional maybe Seeker or Dalbo, we'd have to splint all those together. And if you splintered these together and then put off-axis loading on them, then I would give these teeth maybe 18 months or 2 years maximum before one fractured root, and we have to then go and do extractions of all the remaining lower teeth and go to implants or full dentures. This way, remember, because number one, we're not splinting these teeth together. Number two, we've got intracoronal attachments. So as we bite up and down, there's no off-axis loading on post crowns. So we can really use post crowns as abutments in these situations, because the only loading will be down their long axis. And again, our close-up of the PFM crowns and the fixed movable attachments into the distals and our partial denture. Case study number 3. Interesting one. This is just her, it's not her interclaspal position, guys. This is just an edge-to-edge photo. But again, she's missing, the lady's missing anything from canine backwards, one side, and she's missing the molar teeth on the other side. She needs a little bit of filling work done here and there. So because this lower right canine, perfectly good tooth, we want to minimize the amount of tooth destruction. So I'm going to do a 3/4 gold crown. Unusual restoration on a canine. Patient's quite comfortable. She's in her early 60s. So she's quite comfortable having a little bit of gold showing on the canine. But we're going to do a 3/4 crown so as I minimize the amount of tooth destruction. So it's going to be very, very minimal tooth destruction. And we're going to have a distal female attachment in that. On the other side, we've got 2 crowns here anyway. So all I'm going to do is replace the distal crown again with another female in place. So here we are with my restorations in place. Here's my gold 3/4 crown. You can see it just here. You'll see a close-up in a minute of the female attachment. On the other side, I've not replaced any molars. The patient was quite happy not to have any molar support. She just wanted to have some teeth on this side. So in fact, the metal strut just goes round and links in. So almost this is a one-sided denture. Okay, so this is almost a unilateral denture, but we're getting the male-female, giving one path of insertion, those parallel walls that's stopping the lateral displacement. Remember, it's the lateral displacement that eliminates the retention. So I want to make sure I stop that. I'm stopping the lateral movement by having my fixed movable just in the back there. So close-up of my gold 3/4 crown. Close-up of the replacement crown on the lower left-hand side. And again, just a close-up of the female with the male going into it, the female with the male going into it. So again, these are not classics. These have been chosen. You've seen some of the classic ones. These have been chosen now to be slightly different than our traditional classics. And there's our final restoration at the end. And the good thing about these restorations, I keep on saying, they are stable occlusally. And our final case study, again, a very, very dramatic one. You thought that the patient with the 5 remaining root-filled teeth was going to be a difficult case. Well, this lady's got 3 remaining lower incisors. And she's had some bridge work done in the upper jaw. She's having a partial denture removed from the upper, and we're going to be doing something here. So what are we going to do now? As you can imagine, if we're going to go and prepare these teeth for crowns, number 1, they're going to be very, very thin. Number 2, if I try and cut a box preparation, there's going to be hardly anything left. So rather than do that, I'm now going to have to bite the bullet and have off-axis loading. So what I'm actually going to do now is create a little splintered unit. So I'm creating a bridge first of all. And the bridge is a cantilever bridge. And the fixed movables are going to be in the distal aspects of the cantilever. Again, this is not your classic stable base. Okay? This is a modification. Classic stable base has intracoronal attachments. Here we've got splinted teeth, again, not classic stable base, splinted teeth with the intercoronal attachments now in the pontics. And here's our stable base denture, again, made same technique, drying the mouth off, separate impression for crown work, separate impression for bases, bases linked to crowns with a strut, duralay, pickup impression, try-in, occlusion, occlusal rims, bite, try-in, then to the definitive. And again, closer look at the fixed movables. You can see the female, and there's the male linking in. Again, 1/4 to 1/2 millimeter off the base of the male, so we can have that compression of the soft tissue, not displacement, because the water has got nowhere to go. We're just getting pure displacement. And there again is our final end result. So that's our final case, guys. I hope that you've enjoyed the presentation. I'm happy to take questions now. I can see that we've got some questions. So please write down any of your questions. This is a new technique. When I say a new technique, this is a new technique probably for most of you. This technique has been around since the 1980s. I've been using this technique since I qualified at the Eastman. We did stable base dentures at the Eastman. So that's from 1989. So since 1990, I've been using this technique. Less and less in the last few years because more and more patients are having implants. Go back into the 90s, you can have dentures or implants. A lot of patients chose dentures. Now in the 2020s, you can have dentures, you can have implants. Most of our patients are choosing implants. So these are restricted to our patients who do not want implants for free end saddles, who cannot have implants for free end saddles, have got horizontal, not vertical palates. So we've got more horizontal walls, mucosa for retention, and it's a specific technique. And if you do the specific technique well, as you've seen the technique illustrated to you, you'll have great success rates. And you're looking for anywhere 10 to 15 years before that denture needs to be replaced. When the denture needs to be replaced, don't think the crowns need to. No, if the denture needs to be replaced, it is now a impression of the dentures, impression of the crowns with the male attachments, new male attachments in place, linking them together with struts again. And again, the technician will then make a new base to fit into your crowns. So it's a very straightforward way of working. Your crown should be lasting 15, 20, 25, 30 years, but you can easily replace the base. So hope you enjoyed the presentation. I'll sign off now. Thank you very much for listening. Sorry that we had some problems with the internet connection today. As I've mentioned, I'm happy and we will cut out those parts of the webinar. So we'll rejig the webinar. It will then be available to you for those of you that want to watch it again without the breaks in between. But hopefully you've enjoyed it. And as I mentioned, we're happy now to take some questions. So I'll go on to the Q&A. Okay, so Q&A. Canwell, can I describe what a saddle is? A saddle is an edentulous area. We call it a saddle. It's just an edentulous area, and especially a free end saddle is a edentulous area that does not have a tooth behind it. Anonymous, thank you, doctor, for the lecture. Are there any specific instructions for denture hygiene, such as stable base dentures? Thank you. The denture instructions are clean it with a soft toothbrush and soap and water, and once a week, something like a cleansing solution of Sterident. So the usual cleaning instructions, nothing different there. Canwell, what was the purpose of the Sika cement or screw stuff, which you showed at the beginning? Okay, don't mince your words, Canwell. So the purpose of the screw stuff, Sika isn't a cement. Sika is an attachment. The idea of the screw stuff at the beginning, Canwell, was to give you an idea of how precision attachments worked previously. And they worked previously by using these different types of attachments. So the precision attachment that I've been discussing with you that we use with the stable base is the fixed movable attachment, an intracoronal. The previous attachments used with precision attachment dentures were extracoronal, and there are very many of them. And the two I gave examples of, which were the two most common, were the Dolder bar and also the Sika. Okay, Dalbo attachment, Dolder bars, Sikas, they're the most prominent. And out of those, the Sika is the most normal one that people have used in the past. How much does this stable denture cost in the UK about? If you're talking about how much it costs the patient or how much it costs to the dentist to have it constructed, we'll think whatever you're going to charge for a chrome denture plus the number of crowns. So that's basically the fee. So it's 3 crowns in the upper, 3 crowns, 3 attachments, and a chrome denture. So that's what I would be charged by the technician, and that's how I would be charging out to the patient. Canwell, again, can you re-explain the purpose of Duralay powder liquid? The purpose of the Duralay powder and liquid, Canwell, is to attach intraorally using acrylic, to attach intraorally the struts to the base. So we can then do a pickup impression and have the strut already attached to the base in the mouth, as we've got a nice mucostatic, I won't say impression, but mucostatic appearance. Okay, we've got everything that is fitting in its ideal position in the mouth. Okay, and then we take an impression of it. So it's linking the strut and the base together. Anonymous, in the last case, your photo didn't show the posterior pontics. Were they placed, and how many years does a free end expect to survive? Again, the slide didn't show that, no. We had, we won't call them pontics, we'll call them denture teeth. The denture teeth went back to the lower 6s, and I would expect that that is again going to be 10 to 15 years. What is going to be more likely to fail is going to be the anterior crown work. So it made special dispensation there to make sure that when we prepare those teeth, we prepare them in such a way that we try to do minimum preparations. I know they're incisors and they're very, very thin, so they're liable to fracture off. So we try to do a more minimum preparation. Hence, the aesthetics of it does not look fantastic because we've got a lot of porcelain there, a little bit bulky. We've got metal margins, so we've not taken anything other than just a fine finish line to try to make sure that we've got as much supragingival densine there as possible for strength. Anga, Doc, I would like to ask you the 4th case. Does the 3 central incisors not receive too much vertical forces? They do, Agna. What I've tried to do is make sure that those 3 teeth have been there for a long period of time, okay? And she'd been wearing just a traditional partial denture. Yes, they will take a lot of loading. And nobody is saying to her that this is now going to last you the rest of your life. Okay, we have a consent process. We've been through that consent process. That consent process says, okay, what can we do for you? We can take the 3 incisors out and we can make you a full denture. We can take the 3 incisors out and we can put some implants in and make you an overdenture or a bridge on the implants. We can keep the 3 incisors and make you a traditional partial denture around them. She said no to all of those. She did not want implants. She was scared of implants. She's coming to me because she does not like the partial denture that she's wearing at the moment. So our option then was only to make her a stable base, to give something that would be better fitting and more retentive. And we changed the design slightly from being intracoronal on the lateral and 1 central. Remember, she's got 3 teeth there. So it's 1 lateral and 1 central, okay? To have intracoronal attachments in both of these would have meant too much tissue loss. So we consented her to have Pontics put in place. She's saying, how long will these last? I'm saying probably in the region of 5 to 10 years. But I'm hoping it's going to be more like 10 to 15. So as I've mentioned, with those 4 final case studies, first one, traditional. Second one, traditional, but using those post crowns. Then 2 alternatives were non-traditional, something slightly different. And I wanted not to show you the classic cases all the time, but some different types of cases. Next one, anonymous. Does sandblasted surface of denture cause any damage to the underlying mucosa? No, none whatsoever. It just means we just get a better fit. Canwell, yes, Sika attachment, sorry. Yeah, I think I've answered that. Sika, it's not, Canwell, not cement, it's an attachment. Canwell, sir, do you have some workshop seminars in your academy so that we can practice on mannequins and patients? I think this does require some training. Yes, we do, Canwell. As you see, this particular technique was shown on a phantom head, and we have the opportunity for those people that want to do the partial denture course, excuse me, and learn about stable bases. Then they do all of this same work on the phantom heads themselves. They get their technician to go and do the stages, so both technician and dentist can learn the stage by stage technique. You watch the webinar again and again and again. Read the papers. Like everything, this is a 1-hour webinar on a particular technique. Okay, there's much more to it. But if you read the papers and the references which I've put down, if you watch the webinar several times, you'll start to understand the technique. Now, of course, there are minutiae in the technique, which sometimes it's just experience. And of course, being taught one-to-one, it gives you that experience as well, so you don't have to go and make the mistakes yourself. So yes, we do. We use these mannequins on our at our academy. I'm based in Manchester, Canwell, London and Dubai. I have academies there, yes. Can we subscribe to some events or courses in Dubai? Yes, you can, Canwell. If you go on to, I'll click off on this in a minute. If you go onto the BARD website, and you'll be able then to click on and get some information. So we've got www.tiptontraining.co.uk. You can go on that website and it will show you the courses we do. You can go on www.bard.uk.com. And again, that will give you some of the courses that we do worldwide. Tipton Training is UK based, BARD is worldwide. And if you go on the CAP, C-A-P-P, CAPMER, www.capmer.du, Dubai, then that will give you the courses that we do in Dubai. We also do courses in Singapore. Francis, please can I go through the Duralay part? Francis, I hope that I've gone through that Duralay part already for you in a previous question, but Duralay is a technique, the bead-on technique, which is a really important one if you want to be very precise with a lot of the restorative dentistry you do. If I'm doing a jaw registration between crowns, I would rather use a Duralay jaw registration using that bead-on technique between either preparation and opposing tooth or between 2 opposing preparations than use normal silicone bite registration. Silicone bite registration, it moves too much. Duralay sets rock hard. So you'll get a registration that is set rock hard. It seats together or it doesn't if you use Duralay. So it's got lots of uses. The same use we make Duralay post and cores. A direct Duralay post and core is another technique for it. Another technique here you've seen with the stable base. So it's the bead-on technique which you want to look at. Go through the webinar again and hopefully you'll understand it. Okay, those are all the 15 questions, guys. Again, thank you very much for listening. I hope you enjoyed it, and it's a different style of denture, a different style of restoration that you can give to your patients. So for all those still there, these are the two academies, Tipton Training Limited and British Academy of Restorative Dentistry, BARD. And it's www.bard.uk.com and www.tiptontraining.co.uk. Okay, thanks for listening. Bye for now.